Why is insulin so bad?
In basic terms, it's directly toxic to the endothelial cells, the inner lining of the coronary arteries. And that's why, interestingly as well, and this is something I when I was doing my research writing, I think it was my third book, Stand Free Life, well-controlled type 1 diabetics will, even really well-controlled, will still have a life expectancy 10 years less than average. And the reason for that probably is because of the insulin. Can they do something about it? Yeah, they can lower their carbs. They can lower their carbohydrate intake and therefore lower the insulin requirement.
You're exactly right, Aseem. And to me, insulin is the most inflammatory molecule your body makes. And if you're having these spikes, and a lot of times we don't catch it because there's two types of body fat. There's the regular body fat nobody likes. Then there's the internal visceral, I call it the hot fat, the visceral internal fatty liver inflammatory fat that has a different metabolic pattern than traditional fat. So again, insulin to me is just the biggest marker of inflammation. And what we'll do sometimes is check a challenge with the insulin, have them come in fasting. The hospitals will use a sugar water that they do. We give them a special brand high carb muffin to see, but it's an insulin challenge that we do. We call it the Meadow Muffin Challenge. But are you able to tolerate a certain amount of carbohydrates? And what we'll see is these numbers skyrocket.
In general practice, we don't measure fasting insulin. It's not something that we look at when it comes to appreciating cardiometabolic risk. Here at HUM2N, we've introduced that. And we're seeing a lot of insulin resistance pre-HbA1c elevating, your 3-month average of blood sugar elevating.
Well, you mentioned, Dr. E, about this personalized medicine. And we're fortunate at my clinic that we're able to take people to the next step. Because again, the population testing of just doing the basic cholesterol panel isn't good enough to find that individual at risk.
Yeah.
And we need to go beyond it by looking at the inflammatory markers, the LPA,
Absolutely.
Not just fasting glucose, but sometimes the insulin. So to really find those additional risk factors when it looks like they're doing everything right, but there may still be a hidden risk. Our job is to personalize it for longevity and optimize everything that you're doing to try to find that extra little piece. So I feel by looking at this extra data, you're actually able to kind of catch some of those that might miss by using the traditional risk factors.
I want to bring it back to the context of longevity here. And you touched upon the Dean Ornish. That was your aha moment working with Dean Ornish at 18 years old. Tell us about that study and the outcomes of that study over 30 years in terms of the outcomes of a lifestyle-based approach versus an interventional approach.
So what Dean Ornish did, he came to Omaha from California, so everybody was afraid of him already. But he was a cardiologist that decided if we find people who have had heart attacks, and these are people with 2 and 3 vessel disease that were plugged, and they would remove the veins from the leg and replumb the heart. He taught them how to exercise, how to eat correctly, how to have a stress-free life, and how to build relationships. All the lifestyle things you mentioned earlier. And his group has done better. It's now 40 years later, less hospitalizations, less deaths, less medications in the group that he studied originally. It's a difficult plan for everybody to do, but it just gave us an idea that the medication isn't the answer. And his group actually has done better from it.
Isn't that amazing? That's longevity, quality of life for a longer period.